Thank you. Professor Palmer led the lead today with many questions in one protocol, and that's what we're trying to do with the ibudilast protocol here. These are our disclosures. What we want to do is to discuss the rationale for the use of ibudilast, the pharmacology, the fact that there's an adaptive protocol that used the early cohort looking at the double-blind exposure to drug, and then how this might expand to the effect on survival after completion of the study. We'll look at the adaptive protocol in terms of what we found in terms of loss of muscle strength when people stopped the ibudilast, and how we use that to form a novel composite endpoint. Then we're going to show the relationship of the novel composite endpoint to survival, and also discuss this in the context of per protocol completion, and look at this from the point of view of what Professor Palmer already presented, a treatment epic followed by looking at the survival of that treatment epic. And we're using that in multiple myeloma, some of the studies that Palmer discussed, but also already we're using this in stem cell therapy protocols for ALS and in gene therapy protocols for ALS, single treatment epics. So first we'll talk about the glial pathology. Ibudilast really has an effect on glial activation at different points than the previous drugs that have been looked at in ALS. Ibudilast also has been shown in the NeuroNext study that was performed and presented in Paris, recently published in the New England Journal of Medicine, that it delays the atrophy in primary progressive multiple sclerosis and secondary multiple sclerosis. And then it also has an effect in enhancing glioblastoma treatment with certain chemotherapies. So it has multiple effects across different neurological diseases. What about the pharmacology? Riluzole currently slows the rate of loss of ALS FRSR by 25 to 28%, and we want to see if we can enhance that. Riluzole pharmacologies, there are multiple ones. There's the effect on glutamate release, there's a glutamate transporter activation. Riluzole has weak phosphodiesterase activity, which is similar to what we're looking at with ibudilast. We want to see if we can enhance the riluzole pharmacology. We want to decrease cytokine production by microglia, and there's also an effect on metalloproteinase as well. So the levels that we can achieve with ibudilast are in range that would inhibit all of the phosphodiesterases present, and the brain levels are actually, and spinal cord levels are actually been shown to be higher than what you get in serum. This was an adaptive protocol. We looked at an early cohort, which did not require non-invasive ventilation. Composite endpoint was less than 12-unit drop, 1 per month. At the end of the open label phase, everybody had to have no more than 12-point drop, and not have a drop in neck or leg muscle during the open label phase. This wasn't related to the weakness that we saw in the washout phase. When we looked at the treatment epic, we found 11 of 34 patients in ibudilast and 2 of 17 patients on placebo were associated with more non-progression at a 0.11. And so this will help us in planning the future studies and how many patients we will need for this composite endpoint. What I now want to do is look at the relationship of this novel endpoint to survival. And what we see here in the blue is the non-responders, their survival trajectory over time after they had been exposed to either 6 or 12 months ibudilast. And then this is the responding group. So there was a statistically significant improvement in survival in those people who showed that response, and this will help us in planning our future studies with respect to this drug. The per protocol completion is a little bit more noisy and has other difficulties associated with it, but essentially per protocol completion means everybody did participate in the study and had the same exposure, but this includes responders and non-responders. The previous study was just the responders. So in conclusion, we have a novel composite endpoint defined as less than 12 units, less than 1 unit per month decrease. We had required that going in, and not losing one muscle point in neck and leg muscles in the double-blind open-label EPIC. 11 of 34 patients randomized intention to treat, greater than 60%. On a stable dose of riluzole, we were looking at co-therapy. We excluded tracheostomy, mechanical and ventilation. We excluded greater than 3% particular loss and post-diagnosis vital capacity per month. We excluded greater than 1 unit loss of ALS-FRS-R score per month. We wanted to see what people were like in the plateau phase of ALS according to the Proudfoot phenomena. We essentially had a double-blind EPIC where some people got placebo and some people got treatment. Then everyone got treatment. Then we had a washout. During this washout, we looked at these patients, and then we had a post-open label follow-up, and that was the adaptation that we did to this protocol. These are our baseline characteristics across the board, and they were very similar. We didn't do genetic studies that we're reporting on at this time. The consort diagram shows that more than 70% of the patients completed the study and were available and all patients were available for analysis in what I'm presenting. What surprised us was that when we were in the open label phase, the washout phase, many patients had a decrease in what we call the sentinel muscles in ALS. The cytokinetics group, led by Andy Wolf and Jeremy Scheffner, reported yesterday in terms of how some muscles drop quickly in ALS and others drop less quickly. These sentinel muscles are neck flexion, hip flexion, hamstring. These have been published on before, and this was a group of muscles that decreased when we took the patients off treatment, so that's why we looked at this as part of the composite endpoint. We also looked at the distribution across responders. This was a fairly normal distribution. The orange and the green dot correspond to the treatment allocation, and then this was placebo allocation. This was the 6-month distribution of the endpoint, the ALS-FRS-R, and then everyone was on ibudilast at this point, but this shows you the disease trajectory for each individual patient. We also looked at this from the point of view of spaghetti plots, and this is how we defined the new output. What happened was in our report in Boston, we looked at less than 1 unit change in 6 months and see if we could see anything over time. In the short-term study, there was nothing statistically significant. And then when you looked at, after being on ibudilast for the next 6 months,